Okay, this is a review of the Neuro System. First, we're going to talk about seizures. Seizure is a uncontrolled electrical disturbance in the brain. This can cause you to have changes in your behavior, your movements, levels of consciousness. There's different types of seizures. There's a tonic, which is the stiffening, muscle stiffening. You have clonic, which are the convulsions or jerking. Tonic-clonic, which is also known as a grand mal seizure. That's the stiffening and then jerking. And then we have the absent seizures, which are called the petit mal. This is basically a brief sudden lapse in attention. That is the blank stare that they just look off into the distance and you just think they're not paying attention. And a lot of times they don't even realize that this happened. Some risks of seizures could be metabolic disorders, could be alcohol withdrawal, um, electrolyte disturbances, heart disease, high fever, stroke, substance abuse. I was on a neuro floor. We dealt with a lot of strokes and seizures and cocaine. I saw so many people up there with seizures caused by cocaine. Seizure precautions, you always want to make sure you have oxygen available, you have suction equipment. It says airway here. You always need to make sure that they have a patent airway. You may need to have some something nearby, maybe like an ET tube if they have to be intubated, or even a trach kit. Obviously, you as the nurse would not do that, but you need to have the equipment nearby. The patient should have an IV access. Side rails should be up. They need to be padded. There's actually certain padding that you put on the side rails, but I've been in situations where we didn't have enough because, on a floor when everybody has seizures, we usually would pad it at times with blankets. And Ativan, that is what we typically give patients when they are seizing. We push Ativan into their IV. Seizure management, it really depends on the type of seizure, whether they're stiffening or if it's an absent or if they're jerking. But you want to observe, you want to document. We don't interfere with them. It used to be, oh, hold their tongue so they don't bite their tongue. Don't do that anymore. That is not wise. Also, don't try to hold them down. People say, oh, try to hold down their arm. Well, people have been known to break someone's bones doing that. The only thing you want to do is protect them to make sure that they don't get injured. I mean, if they're about to fall off the side of the bed or something, you would want to protect them. But biggest thing is to ensure that they're safe. You can put them, if you can, on a sideline position. That is, in case they do end up vomiting, they won't aspirate. You definitely don't want to restrain them. You don't want to put anything in their mouth. And time the seizure. I put that in all caps because it's very important. You need to know how long it lasts. That's going to be when you have to document. You have got to document how long the seizure lasted from the time it began till the time it ended. The longer a seizure lasts, the more brain cells are dying. So you need to definitely keep track of the time. Different medications, again, depending upon the type of seizure, but we will use Ativan is quite often given for someone who's actively seizing. We also give them certain anti-seizure medications, such as like Dilantin or valproic acid, Topamax, Lamictal, Keppra. I've seen all of these used quite often. These are all very common. The problem that we have with the anti-seizure medications is, one, they're expensive. And two, they make people feel a little weird, so people don't like taking them. I had so many patients on the floor that had a seizure, and they say, oh, well, that's the first seizure I've had in 10 years. Well, what's different? Well, I haven't been taking my anti-seizure medication for a while. Well, why did you quit taking it? Because I didn't like the way it made me feel, and I hadn't had a seizure in a long time. Well, yeah, they hadn't had a seizure because they were taking anti-seizure medication. So they get that false sense of security where they feel like, oh, I haven't had a seizure, so I don't need this, not realizing, yeah, they haven't had a seizure because they are taking the medication. Status epilepticus, that is a prolonged seizure, more than 5 minutes. This is this is a medical emergency, or it could be multiple seizures over the course of 30 minutes. Again, this is causing brain damage and it can lead to death. Same things, you want to make sure that they have a patent airway, check their ABGs to make sure that they have, they're getting enough oxygen. Again, the IV push of the lorazepam, you could even do it rectally if they don't have a IV access. And then a loading dose of the IV anti-seizure medication. Dilantin is one of them that's mentioned here. Okay, we're going to go into encephalitis. Encephalitis, inflammation of the brain. This, there's different causes of this. It could be alcoholic encephalitis. It could be hepatic encephalitis. It could be viral encephalitis. Bottom line is, it is inflammation of the brain. You'll notice people will have, they can have headaches. They'll have fever. They will have some confusion. And with like hepatic encephalitis or alcoholic, it's typically a buildup of ammonia, and that's with, you know, the liver's not filtering out those toxins very well, so that's a buildup of ammonia in their blood. A lot of times that's also like people with urinary tract infections. Typically it affects the elderly because they're more sensitive, but that buildup of ammonia will cause them to have encephalitis. The treatment with that, with the buildup of ammonia, your treatment's lactulose. Lactulose, you give them, have them, typically it's a liquid that you would drink. It binds to the ammonia and pulls it into the colon, where it is then defecated out of the body. So basically they're just gonna poop all that out, and it's amazing that it clears up pretty quick. It can also be caused by a virus. Different viruses like the West Nile virus or Zika virus, rabies, mosquito-borne viruses. What's that one? I think it's even called like chicken encephalitis or something like that. They test for it even, you know, here locally every summer with the mosquitoes. They check to make sure there aren't any cases. Sorry, I lost my train of thought. If it's a virus causing it, you would want to give them an antiviral medication like acyclovir. Also anti-seizure medications, because anything in the brain can cause seizures. If it's a viral encephalitis, a lot of times you just support them and it is self-healing. All right, Parkinson's, this is a disorder of the nervous system. It affects movement, usually causing tremors. The nerve cell damage in the brain, it reduces the dopamine levels. So one of the ways to help with this is you do give the patient dopamine, carbidopa, levodopa, that stimulates the dopamine receptors in the brain. They need to take this medication regularly. A lot of times it's several times a day. It may be every 4 hours. You need to give it every 4 hours. Nothing drove me crazier than when I worked in a nursing home and found that people were not being given their medication either timely, or sometimes it was skipped. So it must be taken on a regular basis. Sometimes people will, over time, develop a tolerance to the medications. And when this happens, they have to take what we call a medication vacation, which is basically just a period of time where they don't take the medication. And that way that when they start taking it again, the tolerance, they will no longer have the tolerance. Some surgical treatments to Parkinson's could be a deep brain stimulator. This is done where they put electrodes within certain areas of the brain that produces electrical impulses that regulate certain impulses. It's controlled with like a pacemaker. It's literally under the skin and the upper chest, just like a pacemaker for your heart. And the electrodes run up into the brain. The surgery is done with the patient awake because they want to test it to make sure that it is. We've seen, I don't know if you have, but there's been documentaries and stuff where it shows people having this done and they're shaking with really bad tremors, and then as they're stimulating it, all of a sudden they stimulate just the right place in the brain and the person's tremors completely stop, and it's like magic. It's unbelievable. Of course, anytime you have brain surgery, you're going to have risks of infection or brain bleed, seizures, stroke. One of the characteristics of Parkinson's is people, they tend to have this mask-like appearance. Here's an example of it. And if you know Michael J. Fox, the actor who's lived with Parkinson's for a very long time, anytime you see pictures or anything of him now, he tends to have the same exact kind of look. It's a very mask-like facial expression. All right, moving on to Alzheimer's. There's actual structural changes in the brain with Alzheimer's. A lot of people get Alzheimer's and dementia. They tend to talk about them as if they're the same thing. They're not. They're not the same thing. Alzheimer's is an actual structural change within the brain. Dementia, it affects mostly the memory, where they have short-term memory loss. But Alzheimer's is deeper than that. Eventually, as it progresses, people will forget. They'll forget what things are even used for, like a fork. They'll have no idea what you use a fork for. They completely lose all, basically all brain functioning. Dementia, they do not. They will keep mostly, like even their long-term memory. Alzheimer's, they lose their whole personality changes. They lose everything. There's different stages of Alzheimer's. You do have a preclinical, which basically there's no symptoms. Mild cognitive impairment, where they have some changes in their memory, but doesn't really affect too much. Then they go into the mild dementia, where they start having some memory loss. That's when usually people start really becoming aware that something's going on. Then they have moderate dementia. That's when there's a lot of confusion and forgetfulness. That's when they start wandering. They may need help with daily activities, even just getting dressed, going to the bathroom. Significant changes in their personality and behavior. The last stage is severe dementia. They've lost the ability to communicate, and they need basically assistance with everything. I worked in a dementia unit for a time, and it was heartbreaking. There were some of these people that was severe with Alzheimer's, and this one gentleman in particularly, I remember he was very well educated, and he had been a theologist. He had always been, I guess, like working. I don't know if he worked as a pastor but he's always had been very, very religious, and he had lost all like ability to communicate except to curse, and he cursed very creatively, and it upset his daughter so much because she's like, this is not my dad. He would never do this. He would never talk like this. And we just had to explain to her that this was just part of the disease, and and she just had to understand that. It was very sad. Typically, it's diagnosed. You can have it diagnosed with an MRI or CT. People with Alzheimer's live about 3 to 11 years after they're first diagnosed. Pneumonia is a common cause because they forget how to swallow, so they aspirate their food. A lot of the interventions, of course, we care for the patient, but a lot of the care at this point is even for the caregivers or the family, because it is very difficult for them to handle this. Their loved one is no longer basically their loved one, so we do have to give them a lot of support. There are some medications like Aricept. This does not cure the disease. It just prolongs it prevents it from getting worse, or slows down the progression. I guess I should say it doesn't prevent it from getting worse. It just slows down the progression. Aricept, it's basically cholinesterase inhibitor. Cholinesterase will break down acetylcholine, and that is important for memory and thinking. So as Alzheimer's get worse, it produces less and less of acetylcholine. So the Aricept inhibits the cholinesterase, which actually will break down acetylcholine. So it's just a medication to help slow down the progression. All right, Huntington's disease. This is inherited. This is basically, it is genetic, completely genetic, where the nerve cells in the brain break down over time. Some signs and symptoms, they fidget, they're restless, they have problems with coordination, muscle spasms, amnesia, confusion, delirium, hallucinations. Ultimately, it ends in death, and it is an early death. Most people start developing symptoms in their 30s or 40s. There's no cure. All we can do is support them and try to treat basically any symptoms they may have. There are some medications that they can be given. Basically, tetrabenazine. It helps control their movement, like the spasticity or the involuntary jerking. It helps control that a little bit. Some physical therapy, speech therapy. That's all we really can do is support them. And unfortunately, like I said, it leads to death at a relatively early age. There's a lot of genetic testing now where they can look to see if someone has Huntington's, if they have it in their family. And it's always kind of an ethical question. You know, if you knew that it was in your family and that you potentially could have Huntington's disease, would you want to know? Would you want to have this genetic testing done and find out? Some people say absolutely not. I don't want to have that hanging over my head. Some people say, well, yeah, I would want to know because I would want to, plan and, live my life to the fullest and do everything I want to do, while I still can, and possibly even make a decision not to have children to not potentially pass that gene down. So interesting. Think about that. What would you do? Just for my opinion, my personal opinion is I would want to know. I'm a planner, so I would definitely want to know so I could do everything I need to do before before it hits. All right, multiple sclerosis. This is where it's autoimmune. It attacks the myelin sheath, which is the covering over the nerves. That covering helps protect that signal of that nerve signal. So if that myelin sheath is missing, then that nerve signal is going to get interrupted. It's going to affect the communication between the brain and the body. There is no cure for this. There's different types. Basically, there's first one really is not listed on the PowerPoint showing, but it's clinically isolated. That's the very first episode of symptoms. Doesn't really meet the criteria yet for a diagnosis, but it is kind of the first hint that there's a problem. Relapsing, remitting, that's where the symptoms worsen and then they improve. It kind of goes back and forth. Primary progressive, it's slow and steady progression with no remission. They just keep getting worse. They don't have any periods where they get a little bit better. Secondary progression, it's more aggressive. They can have some relapses, but it doesn't disappear between relapsing and they still always have the disease. Sometimes it just may get a little bit better at times. And progressive relapsing, it's least common, but it's a progressive worsening from the very beginning with very few periods of remission, and those are very, very rare and very short. So assessment, you can do an MRI, look for actual lesions in the brain and spinal cord. Interventions, again, there's no cure, so what we do is we just support them. Physical therapy, help with nutritional support, encourage regular exercise, and adapt their living environment, such as making sure that they don't have any fall risks in the house, like maybe throw rugs or possibly small animals they could trip over. Make sure that they have handrails, handrail to get into the shower, handrails to go into like up steps. So basically it's all safety measures. They can be given immunosuppressants. That will help because it is their immune system attacking their body, so you want to suppress their immune system. Now, when you're suppressing someone's immune system to protect them from having their disease progress, you're also at risk of them developing infections. So it's kind of one of those, between rock and a hard place kind of thing. Steroids are used for inflammation. You don't want to give that to them long term because, as you know, with our learning from endocrine system, long-term steroid use is never a good thing. Muscle spasms, you can give them baclofen. That's often used. Guillain-Barré. Guillain-Barré and myasthenia gravis, I do talk about them kind of back to back because they're kind of similar and they're treated the same way. The Guillain-Barré, again, it's a demyelinization of the peripheral nerves. Initial muscle weakness and pain. It's an ascending paralysis. Starts from the feet up. The way I remember, between myasthenia gravis is a descending paralysis. That means it starts from the top, typically with the eyes, and then works its way down. Guillain-Barré starts at the feet, works its way up. I keep them straight, but I think of Guillain-Barré starts with a G, and I just think of ground up. So G and G, and that's just my own little personal way to keep them straight, which one's ascending and which one's descending. It can be caused by the influenza vaccine. It's very rare, but I think that's even on one of the things when you sign to get your influenza vaccine, it even has in the very small print that it could cause Guillain-Barré. Very rare, so don't stress out about it. Any kind of recent infection can also trigger it. COVID has been known to trigger Guillain-Barré. Mono, Zika virus. They're now myasthenia gravis, kind of, like I said, the same thing. It's a weakness of the muscles as well. Again, it's a communication breakdown. Now, this one's an autoimmune condition. This is the descending paralysis. You will typically first see it with like droopy eyelids or double vision. They'll start having problems chewing and swallowing and slurred speech. It moves down. Now, you think it's moving down, Guillain-Barré is moving up. What happens if it gets to the middle? Now, that's your respiratory muscles. So that is one of the complications, is you do need to ensure that that people are able to breathe, that their respiratory muscles are not being compromised. Often they may have to be intubated if it does get to their respiratory muscles, just until the disease subsides. No treatment for either one, but we do, like I said, support measures that may be intubating them. But not all people have to be intubated, but that would be kind of worst case. Some options to help treat it would be plasmapheresis or even giving them an IgG infusion. We'll talk about that in just a second. Some things that would exacerbate myasthenia gravis are like infection, stress, surgery, hard exercise, overheating, crowds, things like that. Those are just some things that would stress their body and could cause an exacerbation of myasthenia gravis. Plasmapheresis. This is when they're hooked up basically to like it looks like a dialysis machine, and it removes these antibodies that are circulating that are potentially causing the disease. So the plasma is separated, and then the blood cells are returned back to the patient without the plasma. Plasmapheresis. That means literally pulling the plasma out. Plasma replaces itself, and sometimes the patient may need to get some albumin, but it typically will replace itself within a day or two. IgG treatment, that's a immunoglobulin It's an infusion, and it's often given to people with autoimmune conditions because immunoglobulins, they're proteins that are produced by your body's immune system. So putting those into someone's body is just kind of giving their immune system a little boost. All right, we are on to, I think this is our last concept, is CVA, stroke, brain attack, all kinds of lovely names. Bottom line is it is a lack of oxygen to the brain that causes brain tissue to die. So interruption in blood flow. FAST is an acronym for a possible to determine if someone is having a stroke. It's an assessment. FAST. F is for face. You want to ask them to smile and see if one side of their face droops. A is for arms. They raise both arms. Does one arm drop down? It's called a pronator drift. S is for speech. Ask them to say a short phrase. Check for any slurred or strange speech. And T is for time. Time is brain. This is a medical emergency. TPA needs to be on board within 4 hours of the onset of symptoms. Sorry. Now, TPA is only used with an ischemic stroke. This is very important. They'll have muscle weakness on one side of the body. You'll usually see suddenly someone's having problems using one hand or one leg, one side of the body. If they go into the hospital, they call a code stroke. First thing they do, code stroke means they're going to whisk them straight and get a CT of their brain. That's everybody else gets pushed aside and they get to go first. That's their little special card to get the fast express to the CT machine. And the reason they do that is because they want, one, to confirm it's a stroke, and two, what type of stroke. Is it ischemic or hemorrhagic? Big difference, and big difference in how you treat. So, ischemic stroke, ischemia, that's lack of oxygen. That's where lack of oxygen and the and the tissue can start dying, just like with like a myocardial infarction. So ischemia means that it is not getting oxygen, typically caused by an obstruction. Could be an obstruction in the carotid artery. It could be an artery in the actual brain. Could be a blood clot. AFib is a big cause of strokes. AFib, it basically have that atrium just kind of like quivers. It doesn't really push the blood into the ventricle. So as it's quivering, the blood starts coagulating and it can throw a clot. And so one of the biggest things, one, if somebody has AFib, they're put on an anticoagulant to prevent strokes. And two, if somebody has a stroke and they don't know, we don't know why, one of the things we do look at is we take a look at their heart to see if they possibly have AFib. Hemorrhagic stroke, that's when an actual vessel hemorrhages in the brain. That's could be an actual brain bleed. Could be by high blood pressure. It could be an aneurysm in the brain that has ruptured. An AV malformation. Could be from anticoagulants, cocaine use, and eclampsia with pregnant women. So with an ischemic stroke, what they would do once they've determined that it is ischemic, they can administer TPA, tissue plasminogen activator. That is used. It breaks up blood clots and restores blood flow to the brain. The question here, why would we not use this for hemorrhagic? So if hemorrhagic means you've got blood flowing into the brain, you've got, and then you give them a TPA, you're going to cause more blood flowing in the brain and probably kill them. So that's why it's so important to have a CT to determine what kind of stroke it is. Now, it's also very common to have somebody with an ischemic stroke that will be given TPA, and then it converts to a hemorrhagic stroke. So I've seen that happen many times. Oh, they came in with ischemic stroke, administered TPA, now they have a hemorrhagic stroke. Oops, we thinned it out a little too much, huh? Sometimes with different kinds of strokes, this was really interesting to me that we had orders to keep someone's blood pressure, their systolic blood pressure above, it was different parameters, but it could be like 140 or 160. And I thought that was so weird. Well, this person just had a stroke. Why are we keeping their blood pressure high? That we don't want it to be too low. Well, it's something called permissive hypertension. And it's basically where they hold hypertensive medications for up to 48 hours after a stroke to keep the patient's blood pressure higher than normal, because what that will do will be to widen the blood vessels and it will improve the blood flow to the brain. So the whole point of that is that higher blood pressure is going to push more blood up into the brain. It's going to perfuse the brain. It's going to get more oxygen there. So it's called permissive hypertension. Kind of cool. There's also, I'm sure y'all have heard about a TIA, a transient ischemic attack, or it's also known as a mini stroke. It's a temporary loss of blood supply or oxygen to the brain. So this could be if someone is perhaps, exercising or doing something, or very stressed, something that can cause, potentially really high blood pressure. The vessels are constricted, and now they're not getting enough blood flow to the brain, and they'll notice differences. Sometimes they may have some visual disturbances, maybe sometimes some temporary weakness, but as soon as the blood flow is restored, then everything goes back to normal. This is, my brother used to play tennis, and he called me one day and he says, after I play tennis, when I'm driving home, I don't have my peripheral vision. And I immediately said, dude, you're having a TIA. And of course he didn't believe me because he's a brother, but and I'm his sister, so I know nothing. But it's basically, yeah, I mean, he was overtaxing himself, and he was getting a temporary loss of blood flow and was having basically mini strokes. He ultimately did end up going and getting checked out because I guess he thought about what I said and realized that once he sat down and everything got better, it just kind of made sense to him. So you'll see that. I've seen patients in the hospital that will come to the hospital with, temporary issues. Suddenly they can't speak, that they've slurred. The family will bring them to the hospital, and once they're resting for a bit, then they've gained their speech back, and the family's like, "Oh, thank you so much. You cured my mom," and basically we didn't do anything, but we take the credit. Okay, here's a diagram that shows the difference between an ischemic and hemorrhagic stroke. Shows the ischemic, it shows the blocked artery. You'll see that. And then the other one, the hemorrhagic, there's your ruptured artery. So this is really good just to kind of visualize the difference between the two. And here we go again, our FAST, spot a stroke. That's our acronym we always need to remember. All right, that concludes the lecture on the neuro system. If you have any questions, please reach out to me.